I'm just finishing up with the mechanical senses, which we got almost through. We almost finished this on Monday, and so there's a little bit of repetition here just to put us back into the context of where we were. So we had just really finished going over these opioid mechanisms, our own opiate type chemicals in our brains, endorphins, and how they are having an inhibitory effect on those pain afferents. Okay, so it's good to have that context. We're talking about placebos because it looks like part of what's happening when we take a placebo for pain is that we are releasing endorphins in this case. If we look at scans of the brain and spinal cord, we see not only a decreased response to pain, we see lower activity in the cingulate cortex, so that area of the brain where I'm having my affective response or my emotional response to pain. It's not influencing the somatosensory cortex, so my conscious experience of my body. So if I'm burning my finger and there's this particular place in that somatosensory cortex, that is still active. But we do see a lowering activity of those emotional responses, which is really what clearly makes pain so annoying and obnoxious to us is our emotional words. Otherwise, it's the somatosensory cortex isn't what is causing us it's hard to say it right, but that emotional response to pain. And so it's just not bothersome anymore. And this is not just a relaxation response. And we're going to see this in a study by Benedetti. I stopped myself there. Benedetti and colleagues, where what they did was they injected people in their hands and in their feet. They injected their participants with capsaicin. So the part of the hot pepper, the chemical in the hot pepper that makes it hot, they injected this into people's hands and feet. And one of my classes, we ended just before this, and I said I would have, you volunteer for a study, you sign the informed consent, and you can always say, hey, I don't want to do this. I would have been saying, hey, I don't want to do this. This sounds so terrible to me, but maybe not as bad as it sounds in my mind, because people are not rating I think they were rating their pain from 0 to 10 or from 1 to 10, and they're not up there at 10, so maybe not as bad as I'm imagining it being. Anyway, so what we're seeing with placebos is the release of opiates, of endorphins, the release of dopamine. This is what placebos are causing, and this is clearly something that's happening in the brain, and we can see this with the study by Benedetti et al. So what they did, if you look at the top row, these are people that had no placebo, and they are rating the pain in these different locations of their bodies. And these are all the different places they were injected, and they were all up around 5 or 6. What they did with placebo groups is, so one group got a placebo cream, so it was a cream that really didn't do anything, and it was put on their left hand, and they were told this is a topical analgesic and this will help your pain. And you can see that they're rating their pain on their left hand as a 3, whereas those other numbers for their right hand and their feet are all still at 5 or 6. They also, so because of the way this is really going up those different sides of the spinal cord and going to different sides of the brain, they wanted to see, I guess, that this crossed, whether or not this crossed the spinal column. And so they did, one group of participants got the placebo cream on their right hand and on their left foot. And you can see that they're rating the pain at their right hand as down at 3. The pain on their left foot, they're rating down at 3.8, and they're still up at the 5 or 6 for the body parts where they did not have, again, a placebo cream. So a cream was rubbed on it, and they were told it was an analgesic, but it didn't do anything. It was a placebo. And so this is clearly not relaxation, because if this was general relaxation, then we would see a lowering of the pain at all of the different sites once they had some kind of placebo cream, and that's not what happened. This happened in a particular location. It also suggests this isn't just a general release of endorphins. This isn't just a general neurotransmitter release. That this is the reason. So when I'm going to go talk about this gait control model, this is the reason it started making sense to me that they were talking about the gait control being down at the spinal cord in the substantia gelatinosa as we're coming into the spinal cord from those dorsal root ganglia. And just so that I mention it here, there's also such a thing as anti-placebos, sometimes called nocebos, where we can worsen pain. And if we tell somebody that they're going to be in a lot of pain, if we increase their anxiety, we can worsen people's pain. There is this relationship between pain and depression, where if I'm depressed, I'm more likely to feel more chronic pain. If I'm in pain, I'm likely to be depressed. And there is a relationship between anxiety and pain. And there appears to be this relationship with GABA, that gamma aminobutyric acid, so that inhibitory neurotransmitter, that is lowered when we are in pain. And if we have lower GABA, we're going to feel more pain. So this would be increasing anxiety, lowering that GABA. There is research being conducted on other mechanisms for relieving pain because of not just the opioid crisis, but the fact that if you take enough opiates, that it increases activity of the immune system, and we can see people get an increase in sensitivity to pain over time. So they've done some research on cannabinoids, so the chemical that is in marijuana, but really not much research has been done on this. What they do know is that it is affecting the receptors in the peripheral nervous system, not the central nervous system. So they took mice and they deleted those receptors in the peripheral nervous system, and then the cannabinoids had no effect on their pain. And then cannabinoids, however, give some memory problems, so it's not necessarily an answer to any kind of opioid crisis. It's a different kind of drug and issue. Capsaicin helps for certain kinds of pain. So the simplest way, and I'm just going to talk about this, how the textbook that I have that discusses it in the simplest way, that it's releasing that substance P faster than neurons can resynthesize it. So they're, for a short time, for a while, they are unable to send messages about pain. And so this is something you might use if you have a chronically kind of sore shoulder, or you've torn your shoulder so that it's going to hurt for a few weeks. You might rub some capsaicin on it. People with arthritis might try capsaicin, where there's a temporary burning, but then it's followed by a longer period of decreased pain. I have just a few examples of top-down influences on our pain perception. So really our background knowledge and our expectations and how this influences our perception of pain. One is a study that looks at expectation. In this study that took place in a hospital, they randomly assigned patients to either be told exactly what to expect and to relax, or they really didn't give the patients very much information at all, which, if you've been in a hospital, is pretty typical, actually, of how they think to treat patients as far as what to expect with pain. The patients who were told what to expect and to relax were sent home 2.7 days earlier, and they requested fewer painkillers than the patients who were not provided with this information. We also, there's also been a shifting attention study, which was done again in a hospital. And while I have this is done with patients, I always think of one of the earliest studies that I read about with this was a man who he had third-degree burns over something like 2/3 of his body. So he was working on gas, something with gas, and it exploded, and he had to be debrided. And if you've ever seen anybody be debrided, what they're doing is so they've put those bandages on around places on the person's body where they really didn't have skin, so those bandages get stuck to the blood vessels, and when they pull them off, it's really painful, and they have to change the bandages. And so the first time they debrided him as usual, and he rated his pain, it was up there at, I can't remember if it was a 0 to 10 scale, but it was up there pretty high. And then the next time they, and that was what was the typical, that was standard treatment. And the next time they gave him this virtual world, so a virtual reality kind of game, although even for this example, the game is pretty boring. So you can imagine what we could do with funner games, but it was, he was in a virtual world, he was in a kitchen, and what he had to do was kind of chase this spider into the disposal and grind up the spider. And after he'd done that, another spider would show up. So he was just, it was just that his attention was shifted, and he rated his pain in that case, being debrided, as much lower. And so it looks like this kind of creation of a virtual world is more helpful than just playing video games or listening to music or other ways of shifting attention, because it really does put you in this different world. And again, that's even a pretty boring kind of thing to do, but it worked. And another study where they looked this time at the content of an emotional distraction, DeWeed and Verbatim had participants look at either positive pictures, neutral pictures, or negative pictures. And those participants had their hands immersed in cold water that was cold enough that it would begin to hurt after a little while, be a little bit painful. They were told to keep their hand immersed for as long as possible, but when it started to hurt, to then withdraw their hand. And you can see that they could spend longer, they could keep their hand in the cold water for longer if they were looking at positive pictures. I do believe there was not a significant difference between the neutral and negative pictures. In 1965, Ronald Melzack and Patrick Wall proposed the gate control model of pain. And it explains these kinds of findings. Even though these are much later findings, we had some research already, and we knew already that the previous model of pain, which basically was, we have these nociceptors, they tell the brain about pain, and that was it. So we knew it was more complicated than that. One of the studies that came out that made it clear that we had to propose something that showed that pain was more complicated was a study that was conducted in 1946 by Dr. Henry Beecher. He was working with the soldiers at Anzio Beachhead that were hospitalized and taken off the battlefield. So if I remember Anzio Beachhead correctly, which I did not go look it up, but I think it was 6 weeks of just being bombed. And so it was miserable. It was frightening. It was an awful situation where you were basically watching the people you know die and hoping that you didn't die in the same kind of, and hearing the sounds that the bombs make, which when they tell you if you're hearing it, then you're going to live, because you'd already be hit by a bomb that you were hearing. So he was working with these soldiers in the hospitals, and for them to get out of the battle and be put in the hospital, they had to have pretty extensive damage. And again, I can't remember exactly how much damage, but it had to be like abdominal damage, losing a hand, something that was pretty extensive, that they could no longer be helpful out in the battlefield. And here they were in the hospital. He was offering them, I think he said to them that they could have some kind of pain analgesic. He never used the word morphine because people were reticent to use morphine. And the soldiers were basically saying, I don't really have any pain, and I don't need any kind of analgesic for it. And they weren't just saying they didn't want an analgesic. They did not seem to have any pain. And he hypothesized at the time that this was basically just they were so relieved to be out of that situation that they weren't really feeling the same kind of pain that we would if we had that kind of abdominal damage in a different situation. I somewhat think that could be a little bit some of that survivor's guilt, that they know that their friends are still out there living through that. They don't know who's going to live and who's going to die and all that. But either way, it doesn't really matter exactly why they weren't feeling pain. They weren't feeling pain when most of us would be in excruciating pain. And so in 1965, Melzack and Wall proposed this gate control model where I'm going to call central control is in the brain. Everything else here is in the spinal cord at wherever that pain, the spinal nerves that are innervating that area, wherever that pain is being felt. Okay, and I'm going to walk you through this model. So nociceptors, I'm going to start with the bottom with the nociceptors, which are small fibers. All right, they are sending excitatory information. They are synapsing in the substantia gelatinosa, that area just inside the dorsal root. And that can open the gate to pain. We can see those are excitatory. They can also directly connect or synapse with the transmission cell, as the T cell is, and have an excitatory effect. Nociceptors are telling us we are in pain. But you can see that there's also substantia gelatinosa that have an inhibitory effect, closing the gate to pain, as they called it. So my large fibers would be the fibers coming in from my mechanoreceptors. They might have an excitatory effect on the transmission cell. So if I actually have a burn on my arm and someone touches that, my mechanoreceptors might also have an excitatory effect. But if you've ever noticed, so one of the things our moms do, not knowing all of this background, but that we've just learned to do, and we do ourselves. So if you bump your elbow or slam your finger or something, a lot of times what you'll do, so I'm going to do my elbow, you'll rub around it, right? And your mom will like rub your arm if you've gotten hurt on the arm, or rub your leg if you've gotten hurt on the leg. And so what that is doing is it's sending excitatory signals to those inhibitory substantia gelatinosa, the SG-, and that is closing the gate to pain, so making it less likely that we're going to feel pain. And of course, we can be getting both of these signals, but we know that those mechanoreceptors can have an inhibitory influence on the information coming from the nociceptors. You'll also see that we have central control, which is the brain, sending down descending messages to the inhibitory substantia gelatinosa and closing the gate to pain. All right, I'm going to go on to my next slide where I continue to show this model and with some ascending and descending fibers. Okay, so these pictures are kind of a lot, and you might want to just pause this and look at the pictures so that you think about the words and everything before moving on, or after, or during, or whatever. And I'm going to start with the middle picture. We've just talked about the gate control model, which is on your left. The middle picture is, and these are images from Laura Freeberg's Behavioral Neuroscience book. It's a really good textbook in a lot of ways, but it's very complicated and she gets a few things wrong, and I got a little annoyed when I was teaching from it, even though in some ways I've taken her information and used it, and certainly her images are so informative that I've taken a lot of those. But so that middle picture is showing the ascending pathway for pain. It's not really showing the effect of the mechanoreceptors, but those nociceptors feeling the pain and sending that information up to up the spinal thalamic pathway to the thalamus, and then those different thalamic nuclei communicating to different areas of the brain. What's also important, or what's going to be important for my points that I'm about to make, is the picture on the right, the descending pathways. So this is central control, or what I sometimes accidentally call cognitive control, but coming from the forebrain, our frontal cortex. So what are we paying attention to? Sometimes we can consciously distract ourselves. The thalamus, the hypothalamus, the amygdala, these are all areas that are involved in potentially responding to pain. Information going through the paraaqueductal gray is important for one reason, that we can release endorphins. So if you've ever had a runner's high, that is you're in a pretty happy experience and not really feeling the pain that you might have gotten from running, whether it's something of not just your muscles, but maybe you've hurt your foot or something and you might not really feel it at all. Going through the Raphe nuclei and then to the dorsal horn. So in the dorsal horn of the spinal cord, where we're back at those substantia gelatinosa, or the SG- in this case, of the dorsal area of the spinal cord. Okay. I'm going to move us back over to the gate control model to explain why I think we probably want to think through that excitatory input to the inhibitory substantia gelatinosa as being the only way that central control can influence pain. And I think it's important to think through our models and what they are giving us. And while there has not been a better model proposed that is really explaining aspects of pain, many different research studies are saying, here's this complication and this complication that I'm going to talk about right now very briefly, hopefully. So we have that as being inhibitory, and when we think about endorphins or distraction or something positive, shifting our attention, which is basically distraction. What was the other one? Knowing what to expect. All of that is really that central control having an inhibitory effect and closing the gate to pain. But there are times when our central control can have an excitatory effect. So if I'm in some kind of acute stress, I might feel more pain. People who are more constantly stressed and anxious feel more pain. If we pay attention to that pain and we think about how much this should be hurting, then we feel more pain. So there's a reason to think that sometimes that central control can have an excitatory effect. How exactly that works is not clear from the models. So I've put quite a lot on the slide here, but this last section was about the sensitization of pain, that we can also see that we do know how this works to a great extent. And some of it is at the point of pain, and some of it is at the point of neurons, neural response. So I'm going to start with the sunburn or damaged skin, inflamed skin, where we have some kind of sore or where we're going to be having some pain. When we have that, the skin is releasing histamines, nerve growth factor, and other chemicals that are helping to repair the skin is the point of all of those. But those magnify our responses to heat and pain. So if we have sunburn, I know, as you know, if you get something hot, or even if you touch the sunburn, you're going to feel pain, inflamed skin, again, because of this release of these chemicals. But another aspect of pain sensitization is how we learn to be in pain. So what happens in learning, and we're going to talk about this in learning and memory and get more specific about how this is happening, but there's a barrage of stimulation to a neuron. So the presynaptic neuron is communicating to the postsynaptic neuron, and this kind of continuous, quick communication, which we're going to potentiate synapses. So we're going to create more receptors on the dendrites, or more dendritic spines. We're going to release more neurotransmitter from the presynaptic neuron. So those synapses are going to be stronger synapses. They're going to respond more vigorously to the same input in the future. Basically, our body, our neurons, learn to be in pain just like we learn anything else. We know that painful stimuli decreases GABA, as I mentioned earlier on Monday. And we know that our body learns how to feel pain and it gets better at it. So this really explains not just the kind of chronic pain, but the fact that if we have some pain that we are having for some amount of time, that area is more likely to feel pain in the future with any little mishap. And I can almost point to my own lower back and say, yep, there's pain there. That the neurons were stimulated, and it's very easy for me to feel pain down there. And so if you've talked to anybody in pain, that you know that this is that this works, unfortunately, for us. So one of the things he talks about very briefly here is that if we are going to take opiates for our pain, that it's better really to start those opiates before surgery, and certainly or immediately after, but certainly not to wait. So a lot of people, we don't want to take opiates because of the fear of becoming addicted, because they are so addictive. But the truth is, if we took them early, and especially if we took them before the surgery, so that as soon as that sort of post-operative pain was occurring, because remember, they don't really have an effect on the
sharper pain that would be happening during surgery. But if we're under anesthetic when that's happening, it's going to be okay. And then as soon as we come out of surgery, we already have some of the desensitization from the drugs, so that we're not feeling that pain. We need to take those opiates for less time. We're less likely to get addicted, which is a little bit, it feels counterintuitive, but again, that it works because of the way the body does learn to be in pain, or how neurons learn to be in pain. Okay, this was the mechanical senses. Again, I hope you guys ask questions if you have them, especially. I think pain is fascinating. I have taught this for a number of years, and I learned something new every time I teach it, and every time I read anything. It's kind of a fascinating topic.